Welcome to the deep dive. Ever felt that twinge in your shoulder?
Mm.
Today, we're diving into rotator cuff injuries. We're using some focused revision notes to pull out the absolute key info you need fast.
Exactly. It's about getting you up to speed on a really common shoulder problem, understanding what it is and why it matters.
Think of it as your quick guide. So let's start right at the core.
Mm.
What is a rotator cuff injury, essentially?
Well, simply put, it's damage, usually tears, affecting the group of muscles and their tendons around the shoulder joint.
Okay.
And the supraspinatus tendon, that's the one right on top, is the one we see injured most often. Honestly, it's the #1 cause of shoulder issues people report.
The most common. Wow. Okay. And your notes mentioned 4 main types. You had that memory jog. SCRA.
Spot on. SCRA. So S is for subacromial impingement. That's where things get compressed when you lift your arm.
Right.
C is calcific tendonitis, basically calcium deposits building up. R for rotator cuff tears themselves, which can be partial or complete. And A is rotator cuff arthropathy. That's where the damage can eventually lead to arthritis in the joint. SCRA.
Got it. Subacromial, calcific, rotator tears, arthropathy. So what actually triggers these injuries? Is it just wear and tear from getting older?
Well, chronic wear and tear is definitely a big factor, just accumulating over time. But it can also be an acute thing.
Like a specific event?
Exactly. A fall onto your shoulder or maybe lifting something really heavy awkwardly. Those can cause tears too.
And repetitive stuff.
Oh, absolutely. Repetitive overhead activities are major contributors. Think about painters, swimmers, tennis players,
Right.
sports in general, certain jobs. And yeah, aging does play a role in weakening the tissues naturally. So if you're doing a lot of reaching or getting older, it's something to be aware of.
So who should be most mindful? Is there a typical profile, maybe?
Yeah, there sort of is. It definitely becomes more common in people over 40. And like we said, anyone involved in activities with lots of repetitive shoulder movements, baseball pitchers, swimmers again, certain trades involving overhead work, they're at higher risk.
Over 40 and overhand activities, pay attention.
Precisely. And there might even be a slight genetic predisposition for some individuals, though that's less prominent.
And physically, what's happening inside the shoulder when this occurs? What's the mechanism?
So the tendons of the rotator cuff are getting damaged. You can get partial tears, just small frays, or complete tears where the tendon is fully detached.
Ouch.
Yeah. It happens because of structural changes, inflammation, often kicked off by overuse, that degeneration we mentioned, or a sudden trauma, and the result. Compromised function, definitely pain, and a restricted range of motion.
If someone comes in with shoulder pain, how do you figure out it's the rotator cuff and not something else?
There are other shoulder issues, right? Absolutely. That's what we call the differential diagnosis, ruling out other possibilities. We need to distinguish it from, say, impingement syndrome, which feels similar but might be more about inflammation and swelling.
Okay.
Adhesive capsulitis, that's frozen shoulder, where stiffness is really the main thing. Then there's bursitis, inflammation of the bursa, those little fluid sacs that reduce friction.
Right.
And glenohumeral joint osteoarthritis, just plain arthritis in the main shoulder joint. A good mnemonic here is IABG, impingement, adhesive, bursitis, glenohumeral.
IABG.
Yee.
Useful. How common are we talking here in the UK?
They're very common, especially as people hit middle age and older. Getting precise UK-wide epidemiological data is a bit tricky, but clinically, we see it all the time. It's a frequent flyer in clinics.
Okay. So what would someone actually feel? What are the telltale signs?
The big ones are shoulder pain, often felt on the outer side and the front of the shoulder, and weakness, especially when lifting the arm or rotating it outwards. Difficulty reaching overhead is classic. Trouble sleeping on that affected side is another really common complaint.
I can imagine.
And the pain often gets worse with specific arm movements, maybe even with some clicking or popping sounds. And we look for tenderness, usually over the front part of the shoulder blade, the acromion, plus that painful arc.
Yes, the painful arc.
Yeah, pain kicking in typically between 60 and 120 degrees when you lift your arm out to the side that suggests impingement. For actual tears, sometimes the pain is worst in the first 60 degrees.
Okay. And confirming the diagnosis, is it just based on these symptoms?
It's usually a combination. We start with the clinical picture, listening to your symptoms, doing a physical exam testing strength and movement. But imaging is key.
Like x-rays.
X-rays help rule out bone problems, arthritis, things like that. But to really see the tendons, we rely on ultrasound or an MRI. They give a much clearer picture of any tears or damage. Sometimes a diagnostic injection into the space near the bursa, the subacromial space, can help too. If the pain significantly improves after the injection, it points towards the rotator cuff or bursa being the source.
Makes sense. So once it's diagnosed, what are the treatment paths in the UK?
It really depends on the severity, your symptoms, how much it affects your function.
Yeah.
We often start conservatively.
Meaning?
Rest, activity modification, physiotherapy, which is crucial for strengthening the surrounding muscles and improving mechanics, and NSAIDs, anti-inflammatory drugs, for pain.
Okay.
Corticosteroid injections into that subacromial space can sometimes give good, albeit often temporary, pain relief.
And if that doesn't work?
For more severe tears, or if conservative management fails and symptoms persist, then surgical repair might be considered, but the decision is always tailored to the individual.
What's the general outlook? Can people expect to get fully better?
The prognosis, well, it varies. It depends on things like the size and location of the tear, how severe it is, your age, your general health, and importantly, how quickly you get treatment.
Sooner is better.
Generally, yes. Smaller tears that are treated promptly tend to have a better outlook for recovery and function.
Are there potential downsides if these injuries aren't managed properly? Complications?
Yes, definitely. If left untreated or not managed effectively, you can end up with chronic, persistent pain. Ongoing muscle weakness is common, too.
Right.
Shoulder instability can sometimes develop, and just a general limitation in your daily activities and function. And a really important point, untreated chronic tears can lead to muscle degeneration, where the muscle actually starts to waste away, making recovery much harder later on.
That sounds serious. Okay, let's try a quick recap. Rotator cuff injuries mean damage, often tears, to shoulder tendons, especially the supraspinatus, caused by sudden injury or just wear and tear. Risk factors: age over 40, those repetitive overhead motions. Symptoms are typically pain, weakness, maybe clicking, and trouble moving the arm, especially overhead or sleeping on it.
Exactly.
Diagnosis involves exams and imaging, like ultrasound or MRI. Treatment starts conservative rest, physio, maybe injections, but surgery is an option for severe cases. Recovery varies, but ignoring it can lead to chronic problems.
You've nailed the key points there. That's a solid overview.
Great. So here's something to think about. Given just how common these injuries are, what simple proactive steps could you, the listener, maybe take every day or week to help maintain good shoulder health? Definitely food for thought.
It is indeed.
For more detailed revision resources, remember to check out PassThemSRA.com. And for some excellent free study materials, head over to freemethra.com.
Great resources.
Thanks for joining us for this deep dive today. We hope you found it useful.